Hello, I'm Andrew Bailey, and I'd also like to acknowledge the traditional owners on the land on which we're meeting today, the Gadigal people of the Great Eora Nation. Um, it's a wonderful thing to look out on a beautiful day like today and imagine what this place would have been like. You know, these beautiful fig trees, or we call them fig trees, just imagining that around the watercourse that runs around the back here. This must have been beautiful country. And I think we should just acknowledge that it always was and it always will be Aboriginal land. So there's a lot in this section, and I really just want to tell you a really Cook's tour of what motivated us to change things and some of the big themes in the changes. Essentially, we've moved from about 4 or 5 guidelines up to 45 because there was an increase in the literature. That increase was in evidence about screening. It was increasing use of e-therapies. There were obviously new trial results. There is a bit of a change in some of our thinking in the panel around the need for differential diagnosis early. The previous guidelines put a bit more emphasis on a period of abstinence to identify the comorbid disorders. And I think the recognition is that probably gets in the way of things. It's more important to engage the person. We obviously have also an increasing awareness of multimorbidity. We've just heard about polydrug use. We're going to hear about physical comorbidity. You know, there isn't a nice little brain in the mind, spirit in the machine. Get my analogy right. You know, these things all come together. We've also had ICD-11 and DSM-5 and some of the differences there. So this was stimulated by the changes were stimulated by a review and adaptation of other guidelines. So there are quite significant guidelines from the local Royal Australian College of Psychiatrists. We obviously have the National Comorbidity Guidelines Project, and that's an extensive document trying to take what that covers in nearly 300 pages and put it into a smaller number of pages for our little section. And then we dipped into some guidelines from NICE as well. So as I say, there's more specific guidance here. And I just give you a quick tour of some of that. I'm not going to go through all 45 guidelines. So the overall context really is about seeing comorbidity as a normal, typical, expected part of the work of drug and alcohol. In the assessment space, we are able to see that we have more evidence for the use of particular instruments, particular screening instruments that might help to identify comorbidity for drug and alcohol services where they don't have the expertise. So we had a bit stronger evidence about the identification of ADHD and of psychosis with screening instruments, and also of the identification of trauma, insomnia, eating disorders, and perhaps personality disorders as well. So these instruments, structured questionnaire instruments, could assist agencies that don't have a strong workforce in terms of training in this sort of area to identify these sorts of conditions. The other thing I think it's well worth putting in, and unfortunately we don't have really strong evidence yet, but that sense of routine clinical assessment when a person does not make the expected changes, looking again to see why. And I think that was captured in Apo's presentation. We need to do more of that. That was obviously just a good practice point. Nothing controversial there. It did seem like the levels of trauma that are present in people presenting to drug and alcohol services really should alert us to structuring our facilities to be more trauma informed. The evidence is not clear there, but it seems pretty much a sensible thing to do. One of the things that's really changed since the 2009 guidelines is the availability of e-therapies. You know, we see MindSpot as a national e-therapy service for mental health. We have a number of other places that people can go to receive e-therapies for their mental health. And where the expertise is not present, in a drug and alcohol service for the treatment of specific mental health conditions, e-therapies may be a suitable adjunct. The issue then is how do we keep coordinated? How do we make sure that we're not referring someone into a black hole and that the advice that they're getting is consistent with the advice that they're getting for their alcohol treatment? But these resources can help us. We've got a bit of a distance to go. It may be something that's useful for us. There's nothing really controversial there. We do see more research about more specific mental disorders. So we're able to make some more specific recommendations about ADHD. We're able to make a bit more specificity in the recommendations about psychosis. Again, also some more recommendations about trauma and PTSD. And to put some information about sleep disorders in there and personality disorders. So these are often not really strong recommendations, but it really picked up on the fact that there is a growing literature and a bit more evidence out there. On that basis, they were all the main points I wanted to make.